Afternoon, everybody. Thank you for joining us today. I'm really delighted to welcome Professor Siobhan O'Dwyer, who is from the University of Birmingham, to talk today about understanding suicide and homicide risk of unpaid carers. So for those unfamiliar with Siobhan, she has done research around suicide and homicide risk related to unpaid carers for more than a decade, conducting studies in Australia, the Netherlands, America and the UK, and her research has informed policy and practice and inspired critically acclaimed theatre and art. So without further ado, I'd like to hand over to Siobhan.
Fantastic. Thanks, Kate. I realise you've all signed up for this, so you're aware of the content, but if at any point this feels like a bit much for lunchtime on a Tuesday, feel free to mute me, go and make a coffee, come back for the Q&A. I won't be offended in the slightest. Self-care is absolutely the priority here, and I will share some resources at the end in case it does bring up anything difficult. Kate, can you let me know if you can see the slides?
Sorry, yes, can we see? Yeah, no problem.
Fab. So before I talk about the suicide and the homicide bit, I want to sort of set the scene and explain why doing research on this is important. I realise this is preaching to the choir, and most of you could probably speak to this slide by yourselves, but just for a bit of context. So I'm going to be talking about unpaid carers. So that's people who provide essential care for family members or friends with long-term illnesses or disabilities. Depending on the stats, there's somewhere between 5 and 10 million of them. Census says 5 million, other estimates say 10. Either way, it's a lot of people doing a lot of care. We also know that the care they provide is estimated to be worth about £162 billion a year, so which is just shy of what it costs to run the NHS. So carers are effectively a second invisible NHS, and they're making this huge social and economic contribution. But that contribution comes at the cost of their own well-being. So there's about 6 decades worth of research that shows that carers have higher than average rates of physical and mental illness, social isolation, and financial distress, all of which are risk factors for suicide in the general population. But until about 10 years ago, there hadn't been any research on suicide risk in unpaid carers. So what I wanted to do today is share the findings from research that I've been leading on suicide and homicide risk in carers, and I'll explain the link to homicide in a little bit, and highlight the implications for policy and practice. Just a sort of linguistic note here. So I'm using the word suicide to talk about people killing themselves. So it's a word that most of us, will be familiar with the meaning. The word homicide here is being used for carers who kill the person they are caring for. So I'm deliberately using the word homicide to avoid the judgment and the misunderstanding that comes with terms like murder or mercy killing. So using it in that very objective way, in the same way that we use suicide. I should note here too that all of the research I'm going to share with you is based on adult carers, but we know there's about 160,000 young carers in the UK, some as young as 5, but there hasn't actually been any research yet on whether young carers think about suicide or homicide. I spent most of yesterday writing the first draft of a grant application on that, so it is research in progress. But for the moment, there's no reason to assume that young carers aren't also at risk. So what do we know about suicide risk in carers? What's happened over the last 10 years or so? So my colleagues and I recently conducted a review of the evidence and found that to date there's been about 60 studies of suicide and homicide risk in carers, including the ones that we've led. And across that literature, there's evidence of suicidal thoughts and suicidal behaviours. So by behaviours here, I mean attempts, in carers from low, middle and high income countries, so places like Zimbabwe, Brazil, Japan, Australia, the UK and the Netherlands, amongst plenty of others. There's also evidence of suicidal thoughts and behaviours in people caring for family members with a really wide range of illnesses and disabilities, including things like cancer, dementia, HIV, schizophrenia, quadriplegia, Down syndrome and cerebral palsy, just to name a few. So this is a really universal phenomenon. It's not limited to any particular country or culture, and it's certainly not limited to any specific illness or disability. The number of carers reporting suicidal thoughts varies across studies, with some estimates as high as 71% and most reports likely to be an underestimate because of the way that the question was asked or reported. Based on all the available evidence, though, our best estimate is that about 30% of carers have thought about suicide while caring for a family member or friend. So that's 1 in 3. We also know that for some groups of carers, like parent carers, so parents of disabled kids, the rate is closer to 40%. Among carers who've thought about suicide, our studies have shown that 1 in 6 carers say they will attempt suicide in the future, and 1 in 10 have already attempted suicide. And when we talk to carers in qualitative research and ask them more about their thoughts, their plans, attempts they've already made, they talk about high lethality methods. So these are methods of suicide that have a high likelihood of resulting in death, which really should dispel any myths that carers' thoughts of suicide aren't serious or that they're too altruistic to act on them. And indeed, when we first started doing this work, a very eminent suicide researcher said to me, "You're wasting your time. Carers are far too altruistic to think about killing themselves." So this research really dispels that myth. We also know that about half, and some studies more than half, of all carers who think about or attempt suicide have never told anyone that they were feeling this way, and they've never sought help. And we'll talk a bit later about why that might be. We also know that although carers experience many of the same risk factors for suicide as the general population, so things like depression and dysfunctional coping, there are risk factors that are unique to the caring role. So these include dissatisfaction with the caring role, so being unhappy with the amount of care you're providing, the type of care you're providing, the fact that you're caring at all, a lack of support for the role, feeling trapped in the role, so knowing that there's no way out of this, that there's no one else you can hand the care over, there's nowhere else the person you're caring for can live and be cared for, and also being in conflict with family or health and social care professionals about the care needs, the care that you're providing, the care that those people are providing. That conflict is also a unique risk factor for carers. We also know, and if you take nothing else away from today, take this, we also know that not all carers who think about suicide are depressed. So depression is absolutely a risk factor for suicide, and including in carers, but not all carers who think about suicide are depressed. And I'll talk about the implications of that later on. So all of that evidence so far I've talked about is suicidal thoughts, suicidal attempts, and unfortunately there's no systematically collected evidence at the moment to indicate how many carers have died by suicide. It's a real gap in our knowledge. But we shouldn't be waiting for death data before we act. The high rates of suicidal thoughts, in combination with extensive anecdotal evidence of deaths by suicide, really provide a clear imperative for urgent action in policy and practice. We also know that for some carers, thoughts of suicide can be accompanied by thoughts of homicide or homicide-suicide, so killing the person for whom they care and then killing themselves. Unfortunately, there hasn't been enough research yet to be able to provide a percentage on that. I can't tell you how many carers have thought about homicide or homicide-suicide, but we do have evidence on deaths by homicide and homicide-suicide. So we recently looked at every carer-perpetrated homicide and homicide-suicide in England over a 5-year period. And by carer-perpetrated, I mean homicides where the carer killed the person they were caring for. And we reviewed all of the publicly available information on those cases. From that, we identified 7 different types of carer-perpetrated homicides. And although homicides, particularly in the case of caring relationships, are highly complex, the 7 types really separate out the key driving force or main motivation behind the homicides, which can then be used to inform prediction and prevention efforts. So the first type we identified, we labeled ending suffering. So in these cases, the care recipient, the person being cared for, was experiencing pain, suffering, or distress as a result of their illness or disability, and the carer believed that their actions would end that suffering. We also saw cases that we refer to as genuine burden of care, where the carer was completely overwhelmed by the physical, emotional, social, or financial demands of the caring role, and there really weren't any alternatives to help them be relieved of that caring role. And for case homicides in this type, the homicides generally occurred in response to a crisis, so a move into residential care, a sudden increase in care demands, And ultimately, what these homicides were about were relieving the carer from that caring role. They acted as to escape the caring role. And what's really important to note here is in both of these types, so the ending suffering and the genuine burden of care, up until the homicide, these cases were characterized by good care, really good provision of care, really good engagement with services, and lots of help seeking. And I'll point out here that we use the word genuine here in terms of burden of care to distinguish these sorts of homicides from other homicides where people in their legal defense claimed that they had been under a burden of care, but there wasn't actually any evidence to support that. We also see a group of homicides where the death is a result of neglect. And so these are homicides where carers really don't have the capacity, the skills, the resources to be providing care. And so the death results because the person being cared for didn't have any of their needs met. And these cases are often characterized by really extreme social isolation, disconnection from services. And so these ones are more an absence of an act than a presence of an act. We also see homicides and suicides perpetrated by carers who have a pre-existing mental illness, usually something like schizophrenia, so something characterized by psychosis, by delusions, by hallucinations. And usually in these cases, the homicide occurs when they're experiencing psychosis or they're off their medications or they're extremely intoxicated. These carers can also experience burden of care, but in these cases, the homicide isn't a response to that burden. It's very much something that happens as a result of the experience of psychosis. We also see cases of homicide that are about exploitation. So in these cases, prior to the homicide, the carer initiated a relationship with the care recipient. So they took on the caring role specifically to gain access to money, goods, services, or housing that the person being cared for received as a result of their disability or illness. And so in these cases, the homicide was usually a continuation or an escalation of that exploitation, or it was a response to the possibility of being found out and losing access to that money, those services, that housing. We also see two types of homicide perpetrated by carers that are linked to domestic violence and coercive control. So in some cases, the carer is actually the victim of that domestic violence. So it's the person being cared for who is actually perpetrating that. And the homicide occurs when the carer snaps or acts to protect themselves from further abuse. But then we also see cases where the carer is the perpetrator of the domestic violence or the coercive control, and the homicide is a continuation or an escalation of that. As part of that work on homicides, we reviewed all of the domestic homicide reviews. It's a form of statutory review that happens when there's a domestic homicide. Sometimes alongside those, you also get safeguarding adult reviews, serious case reviews, those sorts of things. So we looked at all of the statutory reviews, all of the sentencing remarks, all of the media reports. And what really stood out when carers had killed the person they were caring for was the large number of statutory review panels and judges who concluded that the homicide was a rare, isolated tragedy that couldn't have been predicted or prevented. And that's a direct quote from many of the cases. But they aren't actually rare. So we found 65 in a 5-year period. So that's about 13 a year. And that's just in England and just the ones that we were able to identify. And of course, that's not high in comparison to other causes of death, but it's not rare enough to justify the lack of action in policy and practice around these sorts of deaths. And the patterns evident in those 7 types clearly show that these aren't isolated events, that there is a pattern here in these cases. And I flagged here on the slide just a few of the recent examples you might have seen in the press. And what we see here across these types, and you'll see it in the examples on the slides, is that there's no clear pattern here in terms of the illness or the disability, the age of the perpetrator. This really happens across the lifespan. We see parents killing children with disabilities. We see elderly people killing partners with dementia and everything in between. We also saw that in a lot of these cases, although the courts and the domestic homicide reviews concluded that they couldn't have been predicted or prevented, there were clear warning signs and red flags that, had they been recognised and addressed, could have prevented the homicide. Across all the types, there were systematic failures that meant that professionals from health, social care, education, and even the police didn't recognise those risk factors or warning signs, or where they did, they didn't act on them in a timely manner. So in particular, these are some of the things professionals missed that you would think would be quite obvious. So professionals frequently fail to act on obvious warning signs, including disclosure of suicidal and homicidal thoughts. So carers who have told professionals they're thinking about suicide and homicide, disclosure of suicide pacts, particularly amongst older couples, previous homicide attempts, carers who suddenly withdraw or refuse support, and disclosures of really intense dissatisfaction or inability to cope with the caring role. We also see more distally a failure across all services to recognise the enormity of the caring role, just how substantive that is and the toll it takes on people. Also, in some cases, the caring role wasn't recognised at all in professionals prior to these deaths. There was also a failure of professionals to understand that homicide could occur without a history of abuse. So in those types like ending suffering or burden of care, there was very rarely a history of domestic violence or abuse. But if you're a professional and that's what you're looking for as a warning sign, you're going to miss these sorts of homicides. Professionals also often fail to act on concerns raised by family members or neighbours or people like that. And they also failed to communicate across services. So information that one service had about risk was very rarely shared with another service. So in almost every case, there was a lack of professional curiosity and a lack of joined up thinking between health, social care, education, housing, criminal justice. That meant vulnerable carers and the people they were caring for fell through the cracks. We also saw professionals who simply didn't believe that carers were capable of this, even when all the signs were there. And to make this point really clearly, one family member who was interviewed as part of one of the domestic homicide reviews said, professionals need to know that the worst can and does happen. And I think that's a really clear message here, both about suicide and about homicide, that the worst can and does happen, and at much more higher rates than we might expect. And to that end, I want to share now a few examples of things that living carers have said to us when we've asked about thoughts of suicide and homicide, so in qualitative research, as well as some of the things that carers who committed homicide or homicide-suicide had said to health and social care professionals that weren't recognised as a red flag or an invitation to ask about and offer support. I don't know how much longer I can do this for. I'm worried that one day I might snap and do something to her. I know he's not going to leave home like other people's kids and have a happy life. It feels like he's too damaged now. I just don't know how we'll ever get to that point. I don't think about his life in the way that other people think about their children's lives. I view it as a dark thing without much hope in it. I've had to fight for every bit of support he gets. But what happens when I run out of fight? I've given up every part of my life. Now I just exist to care for her, and I'm actually trapped. I can't even kill myself because what would that do to her? I've thought of every possible solution to this mess. Mass murder, putting them all in care, checking into the local nut house. I love my kids too much to kill them, and I can't put them into care for the same reason. So now that we know that suicide and homicide is a serious risk for unpaid carers, what do we do about it? This is my wish list. I appreciate that it is a wish list and that our capacity to do any of these things is impacted by policy and funding and things outside of our control. But a new government brings new hope, and who knows, maybe with some time we'll see some of these things happen. So the first thing that's not actually on this slide, but I think is the most important thing, is to understand that carers who are thinking about suicide or homicide are in crisis. And what they need is support, not shame, not judgment, not persecution or prosecution, but understanding and support. We also need to be aware that carers with physical or mental health problems pre-existing, there before they took on the caring role, may need additional support, particularly where the caring role is likely to exacerbate them. And so we really need to be screening for those pre-existing physical and mental health problems so we can offer that support from the outset. And alongside this, we need to recognise the importance of joined up multi-agency working, especially for people with pre-existing problems. We also need to ensure that we're providing carers with proactive support, so making sure that they're signposted to or get access to support that is proactive, not reactive, and includes respite care. I think it's the single biggest thing I've heard from carers over the years. It's the number one thing on their list is respite care. If they could just get a break, most of them could keep going. We also need to be routinely asking all carers about suicide and homicide, not just those with mental health problems or who outwardly look like they're struggling. As I mentioned before, not all carers who contemplate suicide are depressed, and often in general practice, in frontline social care, we only assess for suicide risk if someone meets a threshold for depression. But if we do that, we're missing carers who may be having suicidal thoughts. And it's really important here that frontline professionals don't assume that someone else is doing this. So social workers and charities, for example, will often assume that GPs are asking carers about suicidal thoughts. But many GPs don't know which of their patients have caring roles. And even when they do, it's very rarely something they focus on. We also need to ensure that if we're going to ask about suicidal and homicidal thoughts, that we then provide safe spaces when people say yes to those questions. So we need to make sure that we provide carers with safe spaces to share thoughts of suicide and homicide without fear of unreasonable prosecution. Sometimes prosecution is the right thing, but unreasonable prosecution, unnecessary sectioning, or inappropriate removal of the person they care for. And I have to say, having done research on this topic for over a decade now, these are the two biggest fears that carers have when it comes to disclosing thoughts of suicide or homicide: that they'll be sectioned, that they'll be detained in hospital, and that the person they care for will be removed. And in some cases, that may absolutely be the best course of action. So certainly that neglect type that I talked about in terms of homicide, these are people who cannot care. They cannot provide the basic level of care that's needed. And it may be that the person they care for does need to be removed from their care. But in most cases, all carers want and need is to be able to safely offload these thoughts. And again, it's really important that professionals don't assume that someone else is providing that safe space. But all of that said, we also need to be mindful of our obligation to vulnerable people with long-term illnesses and disabilities. And this is where suicide prevention gets tricky. If you've done any suicide prevention training before, you'll know that it focuses on supporting one individual at risk. But we know that carers come as a set with the person that they're caring for, or in the case of parent carers, often with other children and a wider family network. So we need to balance our efforts to prevent suicide with our obligations for safeguarding. And we also need to recognise that in some cases, carers will disclose thoughts of suicide or homicide specifically because they know that professionals have mandatory safeguarding responsibilities and they're desperate for them to enact them. And that's often the thing we hear, although, more than half of carers have told us that they've never told anyone about their suicidal thoughts or their homicidal thoughts. It's really heartbreaking to hear from the ones who say, I did tell someone. I told my GP and nothing happened. Or, I told the social worker and nothing happened. Even more concerning is when something happens and it's the wrong thing. I told my GP and they put me on the pill. That was one of the stories we heard. So it's really important that we recognise that safeguarding obligation is there as well, and that we need to meet that duty too. The recommendation that's not here, but I think is equally important, is that if we're going to do all of these things, we also need to be supporting the frontline staff who work with at-risk carers. This isn't easy stuff to do, particularly that balancing suicide prevention and safeguarding, and we need to make sure that they're supported too. So really taking a holistic view when we think about carers and the people they care and the professionals who support them. So that's quite a quick sort of whip through of all of the evidence so far on suicide and homicide risk in carers. I want to open it up now for questions and comments and discussion. This is still very much an evolving area of research. There's huge amounts of work still to do, not just in terms of filling gaps in knowledge, but also thinking about how do we now translate this into policy and practice. So I'm really open to a conversation there. The QR code that's on the slide goes to that review paper that I mentioned. I will also put a link in. There's a new paper on parent carers that just came out this week. I'll put that in the chat. And I will ask Kate when the homicide paper comes out to circulate that as well. It's not out yet, but it will be hopefully by the end of the year. And I'll put some resources in the chat too, just again in case this conversation has brought up any difficult feelings and you need some support after this session.